Hi, my name's Dr. Kirsty Sagara, and I'm here to do a little deep inquiry into the periactal gray and how it relates to somatic touch, and specifically working with folks with trauma responses in the body and PTSD and complex PTSD. I decided to create this section of the course for free so that folks I've worked with in the past could maybe have a deeper understanding of what this course is about and what I'm up to. So before we go in any further, I'm just going to have you find your ground, find your feet touching the floor, and take a moment to take a breath in and out through the nose. And even take a little look with the eyeballs around the room that you're in and just notice the space and staying present as we begin to discuss this material. So I have a cat who's trying to start to participate. So I'm going to move her to the side. Okay, Kiki, you got to chill out. So with the research I've done to connect threads of understanding what mechanisms are involved in processing our experiences that may arise with PTSD and CPTSD, I became curious as some of the common threads that are presented in trauma work, whether or not they're accurate. There's a strong bias in some of the literature right now towards this idea of a dorsal ventral vagus nerve and there being a braking mechanism around the heart rhythm coming from the vagus nerve. And my question is whether or not that's actually accurate and whether or not there might be other mechanisms involved with regulating those trauma responses. And so a big part of this somatic touch course is really working with the periactal gray system as a mediator of those trauma responses. And the other aspect is what I've learned is that we are indeed complex holistic systems, and our tendency to be reductionistic in our thought inquiry leads us astray from the holistic model that would include many complex biosocial systems and ways of experiencing life inclusive of epigenetic models of understanding. So what do I mean by that? Well, in the fields that I work with, the holistic model and approach is the dominant approach to the body. And we are more interested in looking at somebody from a holistic paradigm as opposed to pathologizing or diagnosing a condition according to the DSM-5 or other methods of diagnostic criteria with allopathic medicine. And what I'm really interested in is supporting the holistic mechanisms of the body, supporting healing and vitality in the system, and removing any blocks and mechanisms in the body through somatic dysfunction, which is an osteopathic term. And I guess you could say this has kind of been a bee in my bonnet for several years. I've already written some papers around the vagus nerve and why it's not just the vagus nerve. And you can find that at my blog at drkirsty.com. It's also in my doctoral thesis. And I have written on this before, and I just want to restate that our experience of PTSD and CPTSD is not because of or mitigated solely by the vagus nerve. The idea of breaking down the vagus nerve into dorsal, back, and ventral front comes from an analogy likened to the ends of a wire that split into insertion points, like a positive and negative wire in electronic systems, one being in front and one being back. As I write this, I realize how ridiculous it is to compare how human grows to an electrical model. As an embryo, We grow out of many fluid systems of limiting and inner tissues with a cerebral spinal fluid, the CSF, in command at the center, washing around the future brain and spinal cord. So let's just consider this for a second, with a lot of the trauma literature claiming that we can directly treat the vagus nerve and that is the primary mechanism. And if that is great, but what if it isn't? And what if the periactal gray mechanism has more to do with our response patterning than other forms? My cat just keeps wanting to get into this video, so I am gonna keep moving her out of the way. So nerves grow in embryology. They're restrained like guy wires from the arterial growth. As arteries form an embryo through the fluid biodynamic fields, the artery restraints acts as guy wires on the nerve growth. The nerve cannot grow faster than the metabolic growth of the artery. In osteopathy, we say the rule of the artery remains supreme. In other words, if there is no free flow of blood and lymphatics throughout a system, there is a block in health expressing itself via vitality. When we understand these concepts, we can become aware that the vagus nerve expresses the restraint of the artery, not the vagus nerve controlling the artery. And this is where I inherently think a lot of the models that are presented in trauma are wrong. This is important as we can treat the restriction in the arterial vis-a-vis a nerve, or a restriction in a nerve via treating the arterial restriction. And here's a really cool image from the Bleshman library showing a very early on in embryological growth, and you can see the heart and the liver and the veins and the artery and the early growth in the system. It's all connected. And we weren't separate right from the get-go. You can see the wholeness within the system here. So coming back to holistic understanding, we always need to keep in mind the complexity of the human form and how it grows itself. Within this, healing mechanism arises naturally if supported by the inherent intelligence it carries within. We don't need fancy gadgets, pharmacology, and psychology to support a system to find its own resonance, support, and health. There are natural processes that are inherent in the system that know how to self-correct and heal. This is the basis of osteopathy, chiropractic, craniosacral osteopathy. Many of these holistic systems are supporting the body in its own ability to heal. So looking at the periactal gray with regards to PTSD and CPTSD, there is further support for noticing the importance of the periactal gray in the regulation of responses and the arc of responses. So instead of thinking just like dorsal ventral, we think about a full arc of responses. So there might be something like happening, and as the trauma continues, there's something that happens at the end. So the sympathetic is expressed as fight or flight. So that might be an initial response. And then as it arises, we might move into a flop freeze trauma responses. The dorsal ventral models assert that the dorsal is the fight or flight response, as sympathetic in the arc to flop freeze, or what we call parasympathetic expressing as emotional shutdown. So that's the end of the arc. And we'll see that more in some future graphs. So here's an example from the paper that I sourced earlier of where we might have a hyperarousal or hypervigilant response, active response with a sympathetic dominance, then moving into like a freeze, tonic immobility, and then what they're calling a parasympathetic dominance is more moving towards emotional shutdown or even disassociation. And this is the arc response. And this is very different than a model presenting than the dorsal ventral models, where you have like the social engagement system in the front, as a piece or a mediator of what's happening. This is really looking at it from an arc of responses, and that can be really different with PTSD versus CPTSD, where we're involving more developmental trauma ongoing versus a one-time life event of trauma. So they have different flavors, if you will. So in humans, tonic immobility has been described as a psychological defense to trauma. And during a state of tonic immobility, somatomotor activation resembles a fight or flight response with increased muscle tone and striation via secretion from the hypothalamus. So from a palpatory perspective, you may notice a tensional quality in the tissue. In contrast, lateral periapital gray, the ventral lateral periapital gray coordinates passive defenses by promoting parasympathetic, as opposed to sympathetic nervous system expression. And this was a research done in rodents. Here, top-down projections from the central nucleus of the amygdala towards the ventral lateral periapital gray are thought to signal for upregulation or parasympathetic nervous system expression. And this is the top of the arc, right? Starting to go into parasympathetic, but not quite fully parasympathetic as it is with the emotional shutdown. On a side note, we have all these braking mechanisms, which are a little bit like the dorsal ventral wiring. I mean, where's the brake in the human body? We don't really have a brake. But obviously with positive and negative feedback loops, where positive feedbacks amplify change and negative feedback loops help to negate those changes in the body. We might see that as like a potential, like a negative feedback loop as a braking mechanism. So concurrent activation of the ventrolateral periapital gray applies a brake to the sympathetic expression through inhibition of the downstream effects of lateral subunit. Although the braking mechanism is not well understood, ventrolateral periapital gray projections are hypothesized to target the rostral ventral medulla and the ventral midbrain, which in turn modulates the activation of premotor neurons towards the spinal cord. On balance, this pathway would have the effect of modulating striatal motor loops to induce the immobile state. Although research into the system is primarily preclinical and generated via rodent models, it is hypothesized to apply to humans who also display passive defense states during episodes of inescapable threat. So there's some hypothesis basically around this idea that there's a switch, if you will, a brake that can switch from sympathetic to parasympathetic. In addition to mediating the ventrolateral brake of the sympathetic nervous system, the ventrolateral periapital gray also signals expressions of an opioid-mediated analgesic. So we also know that in a lot of this area, there's the cannabinoid receptor network around the amygdala, and it's the PAG with the signals going from bottom up might interpret that and then switch it over towards sending an expression of opioid mediated analgesic, so decreasing the pain signal. And then the last stage of the arc is the emotional shutdown. As a defense cascade, shares many of the same characteristics as tonic immobility. This stage is synonymous with fear-induced fainting in animals and is associated with increased expression of the parasympathetic nervous system, cessation of motor commands, and release of the opioid-mediated analgesic in rodents. Unlike tonic immobility, emotional shutdowns involves a complete loss of muscle tone, as opposed to the waxy hypertonicity resulting in the appearance of death in animals. I think that the arc piece is really important because we're really talking about an expression within the capability of the human form around trauma responses. And any one person may express any of these, and it becomes quite different, I think, with potentially with developmental trauma that's ongoing. Just to highlight for anybody as a hands-on practitioner, um, that there's research that has revealed that lesions in the ventrolateral subunit reduce the expression of conditions in the immobility in rats, and stimulation of the ventrolateral subunit produces immobile responses. Moreover, the lateral findings have been replicated with descebrate animals as well, suggesting that ventrolateral perioctal gray projections are both necessary and sufficient to produce motionless state. What I also think is interesting is the choice of the word lesion here, that there needs to be lesions or injury to the ventrolateral subunit. And I've noticed over the years in clinical experience that many people with trauma history, when they come in with their raised sympathetics, they're presenting often like somebody who's had a car accident and experienced whiplash. So the posterior side of the neck, all the muscles and the nerves have a lot of tension expressed, which also may really talk about here the cerebellum, a hindbrain region associated with motor responses and with evaluation of emotional states is thought to support the ventrolateral perioctal gray. So if we have posterior tension in the neck and there's a lesion, there could have been what I think of is like a whiplash quality response in the neck, head, and lower regions of the brain. And this has been validated time and time again in my clinical experience. I've seen this repeated many times and had success. And then this is just demonstrating all those cascades that we were talking about and how that's related through this whole region. I'll just leave that there for you to take a look at for a moment. So with the myriad of research, it can be challenging to deduce what in fact is going on in our response to trauma stimulus. It is possible to look at the previous research and see an arc of trauma responses in the sympathetic fight, flight with an arc, a flop, freeze, tonic, and then immobilization. So to an expression of parasympathetic with emotional shutdown. So we just, when you look at that graph I presented earlier, you'll see this whole arc and relationship. Furthermore, I question the idea of braking mechanism in the system is an analogy I find lacking in expressing the holistic nature of our systems. We don't operate from an on-off binary code. Our fascial system is the largest sensory organ and is left out of many of the research studies and a primary input of understanding our environment. We have bottom up and top down systems in the top down systems in the body. A lot of neurobiology research seems to be hyper focused on the brain being the top down mechanism, but my specialty is more in the fascial systems or connective tissues of the body. And we know through the mechanoreceptors that the fascial system is the largest sensory organ in the body and is, as a somatosensory organ, is reading your environment continually. And through that, it is sending signals up into the ANS, up into the brain through the PAG. And for me, that is the primary mechanism And then having it filter through the periactal gray as well as the other systems around the periactal gray, because we can't really separate a brain. I think that's really important to pay attention to that and how we look at supporting trauma. And that's how somatic touch works, is because it's treating the fascial system and then has a lot of awareness of treating the base of the head and the brain and having that be supported. So I'm coming into an osteopathic lens of treatment. In the following slides, I'm just going to share some excerpts from my second doctoral thesis, focusing on female body osteopaths and their ideas that they presented through the research. Dr. Burns, a DO work led to the term somatic dysfunction. It's current osteopathy and classic osteopathy is known as a lesion. To add to the previous definition, somatic dysfunction is defined as impaired or altered function of related components of the somatic body framework system, skeletal, arthrital, and myofascial structures, and related vascular, lymphatic, neural elements. So Dr. Lewis Burns, she did a lot of research and developed the somatic dysfunction concept, and I just think it's important to acknowledge where some of that work comes from. And we use the acronym TART, is often used for diagnosing somatic dysfunction, which is tissue texture changes, asymmetry, restrictions of motion, and tenderness. And that we have several reflex arcs. So not just the periactal gray reflex arc that I was talking about earlier, that will help you understand how to find the fulcrum of the treatment. We have viscerosomatic, which are localized visceral stimuli producing patterns of reflex response, segmental related somatic structures. Somatovisceral, localized somatic stimulation producing patterns of reflex and segmental related visceral structures. And visceral, localized visceral stimuli producing patterns of reflex and segmental related visceral structures. And then somatic, localized somatic stimuli producing patterns of reflex responses and segmental related somatic structures. Additionally, that we may want to also pay attention to psychosomatic and psychovisceral as a reflex pattern. With the continued work in the chronic pain science, the pain in the brain model is valid with person-centered treatment versus diagnosis-based treatment, and one may be valid, the individual and their personal story. It's incredibly important for practitioners to pause, listen, be careful with the words they choose and how they mirror their patients. So I just want to thank you for taking the time to listen as we do this deeper dive into how the periactal gray and the reflex arcs is, with the periactal gray may be a important component in how we assess and treat patients with the osteopathic manual therapy model, with regards to also applying somatic touch as a basic principle in treating PTSD and CPTSD. Thanks for taking the time out of your day to join me.